It is an honor for me today to be able to stand up here and to introduce to you Dr. Thomas LaVeist, who is the William C. and Nancy F. Richardson Professor in Health Policy and Director of the Hopkins Center for Health Disparities Solution at Johns Hopkins Bloomberg School of Public Health. He holds a joint appointment in the Department of Sociology and the Johns Hopkins School of Medicine, Department of Oncology, and is a faculty associate in the Sidney Kimball Comprehensive Cancer Center and the Hopkins Population Center. He's served on various boards and currently sits on the external advisory committees for the University of North Carolina School of Public Health, the Robert Wood Johnson Foundation Health and Society Scholars National Advisory Committee, and the National Urban League National Health Advisory Board. He is chairman of the board of directors for Daystar Educational Research, and Dr. LaVeist has received his bachelor's degree from the University of Maryland Eastern Shore and his PhD in medical sociology from the University of Michigan and postdoctoral fellowship in public health at the University of Michigan School of Public Health. Dr. LaVeist joined Johns Hopkins faculty in 1990, and he teaches courses in minority health and in public health policy. His research is focused on minority health and has been funded by the National Institutes of Health, the National Center on Minority Health and Health Disparities, the Center for Disease Control, the Agency for Healthcare Research and Quality, the Brookdale Foundation, the Commonwealth Fund, and the Russell Sage Foundation. So please join me in giving a nice warm welcome to Dr. LaVeist today.
Hi, good afternoon. Good afternoon. I know this isn't church, but you can give me some response. If I call, please do respond. Okay. Thank you for inviting me. It's a pleasure to be here back in Missouri. And I know I have a lot that I want to try to say to you in the time that I have allotted. So let me get right to it. The first thing I want to do is a commercial and plug for my research center. And I'm sorry, but I have a captive audience, so I'll take advantage of it. The Hopkins Center for Health Disparities Solutions was established 10 years ago, in 2002, with funding from the National Institute on Minority Health and Health Disparities. And we're very proud to have survived 10 years and hopefully will survive many years longer. And to celebrate that, we have two initiatives that I want to just mention to you. One is a documentary film that we're working on called The Skin You're In, and this is a film about African American health and health disparities, what we've learned, what the research is telling us, and what we might do about health disparities. And some of what's going to be in the film is what I'm going to talk to you about today. And the other initiative is the International Conference on Health in the African Diaspora, which has become the major source of stress in my life right now. This is a conference that we're planning for just July, and we will bring to Baltimore people from throughout the hemisphere who are working on black health issues, from Canada to Argentina, everywhere in between. And hopefully some of you will consider coming to the conference and going to the website and seeing what it's about. We're going to have really a wonderful program. So that's it for the commercials. So I'd like you to imagine this society without health disparities. Can you do that? What would that look like? And how would we get there? What would have to change? What would we have to do for us to get from where we are now to where we no longer have need for conferences like this one? Now, I asked this question to many audiences, and I won't ask for your answers now, but I want you to kind of think about what your answer is and hold that in your mind until we get back to the end of the talk, where I'll ask it again. But when I ask people about this, how we would get there, the fundamental issue here is, why do we have the disparities? What causes them? And we need to figure that out before we can figure out how we get to the point of that imagining. When I talk to people, especially people that are not in the health sciences, but also some people that are, the answers that I get are things like, well, disparities exist because there are biological differences. So there's some gene that's causing heart disease and cancer and stroke and diabetes and HIV and homicide and injuries, and it also makes you black right? It's that same gene, right? There's a gene that does all of that, right? But this is the kind of thinking that we often fall into. Or you'll sometimes get, well, it's not really race, it's really socioeconomic status, right? In which my response is always, well, even if that was true, why would that be any more acceptable? And we need to start challenging the way that we think, because there are some things that we sort of automatically fall into, certain ways of thinking that we fall into. Well, I can imagine the society without health disparities, because I can think back to when I didn't know that they existed. And it seems like it wasn't that long ago, but it actually was when I think about it. It was when I was in graduate school, and I was working on my dissertation. And for those of you that have written a dissertation, you will be able to relate to the tedium, boredom, and isolation of writing a dissertation. I see some smiles. You know what I'm talking about. So I was having one of those days. One of those days. I'm sure you know what I mean already, right? And I was trying to find something to do other than work on that damn dissertation. And so I decided to take a walk. I was taking a walk along downtown Ann Arbor, Michigan. And if you've been to Ann Arbor, Michigan, you know that that was a pretty short walk. So I found myself in this used bookstore. And I walk into the used bookstore, and I immediately turn to and head towards the clearance section. So yes, this is the clearance section of the used bookstore. Did I say I was a graduate student? This is what I could afford. So I'm over there in this section, and I'm looking for something to read. Anything that does not have a bibliography in it. I mean, I'm open for anything, as long as it wasn't academic. And I come across this book, which I still have on my shelf at home. This is a book about the Titanic, which tells you something even more about my mental state at the time. So I start thumbing through this book. I'm thumbing through this book in the clearance section of the used bookstore, and I come across this page, and in the book, it's talking about survivors on the Titanic. Well, this was the first thing that was new to me, because at the time, I didn't know that there weren't any survivors. I figured the story was pretty clear. The ship went down, they all drowned, and that was the end of the story, right? This was before the movie came out, by the way, right? So I hadn't seen the movie yet, so I'm not that bad. But what's really fascinating, I come to this page where they're talking about these survivors. They're talking about the female survivors, and they're talking about them who survived as a function of the class of ticket that they had, which was stunning to me, right? And so I'm going through this information that they're providing, and I start calculating these rates, which tells you something even more about my mental state at the time, calculating mortality rates in the clearance section of the used bookstore, right? I was gone at that point. Clearly, I was going to be a researcher, right? So I've since recalculated them and made sure that they were correct, and these were the rates that I found. That the class of ticket predicted whether or not you survived the sinking of the Titanic, which was stunning to me. All three cabins of the ship went down, first, second, and third class, yet which cabin you were in predicted whether or not you survived. Now that we've all seen the movie, we have some idea about how that happened, but it was fascinating to me. It seemed to me this was a perfect analogy for the U.S. healthcare system. Big, expensive ship, giving out unequal treatment, destined to hit an iceberg and sink. But when you think about why it happened, what happened was it was really about scarcity and resource allocation. There was only enough lifeboat space to accommodate 53% of the souls on board, and when it comes to the scarce resources, who you are determines who gets access to what. An even better analogy of the U.S. healthcare system. So now, okay, that was 100 years ago, April 15th, 1911. That could never happen today, right? Well, I promise you I did not Photoshop this, except to write in coach class and first class. This is the U.S. airliner that landed on the Hudson River back in 2009. And as you can see, the first class cabin has life rafts, and the coach passengers are standing on the wing. By the way, the conference organizers, about my return flight back home, You know. Anyway, so now this is fundamentally what health disparities is about. It's about resource allocation, who gets access to what. Now, the topic of health disparities really came onto the national scene in a big way in 2002 with the publication of the Institute of Medicine's report, Unequal Treatment. Many of you, I'm sure, are familiar with this report. Now, this was not the first report written on health disparities. In fact, it wasn't even the first report from the IOM on the topic. But this report was different. This report has placed the topic on the health policy agenda of the nation and has stayed there for 10 years now. Why this report, I believe, why this report has been so successful where previous reports weren't, was because previous reports would come out. For example, in 1985, the Secretary of Health and Human Services, Heckler, issues the report on Black and minority health, which was a huge multi-volume compilation of health statistics demonstrating dramatic differences by race and ethnicity in health. But mainly it was a report on mortality and morbidity rates. And you saw the bar charts and the huge differences across the different groups. But the response was, well, this is complicated. It's an access to care issue. It's patient preference and patient behavior. It's the broader social environment. It's all of these things, and that's complicated, and that's not really something that we can deal with within the healthcare industry. But what the IOM does with this report that I think was really a stroke of genius was they collected high-quality research that looked at disparities by race or ethnicity among people that had health insurance, had access to care, identified that they had a symptom of some sort, and sought care, got into the system, and actually got seen by somebody. And said, once we've taken all of the barriers out of the equation, do we have disparities in quality of care among people that have access? So there's nothing about access in this report. You know. And once this happens, you now have to acknowledge we've got a problem, and we can't assume that this problem is really something about patient preference, because these are all patients that wanted care and showed up to get it, right, and tried to get it. So this is what placed it on the agenda. Now, ever since this happens, we've used a social justice frame to raise awareness around the problem and to argue for resources being allocated to the problem. And I think we've done a fairly good job in terms of raising awareness among policymakers, at least. Here's a quote from a prominent national policymaker who says, "A key test for any new system is its ability to provide access to quality care for the poorest and sickest among us. And the elimination of health disparities must be a critical goal. No American can be left out." Anybody have an idea who that is? Do not make me call on you, because if you weren't in my class, you would know that I will do it. And it's like I love doing it. Anybody? You would think Berwick, but this is former Speaker of the House and current, I was going to say current Republican candidate for president, but he announced the other day that he was going to suspend his candidacy next week. So he's in this limbo state right now. But
So that's why we can trust him?
no, the point is that there's awareness there. Here's another one. One more. African American males die sooner than other males do, which means the system is inherently unfair to a certain group of people, and that needs to be fixed. Any guesses there? Don Berwick? Bill Clinton? No. Who's that? Says Sarah Palin? Well, you're not that off. This was former President George Bush making this statement. So I don't see the point is that there is awareness. The awareness of the problem is there, and it's not about whether or not they know. There's this, so. Now, unfortunately, the president wasn't making this statement in the context of announcing a new initiative to fix the problem. Rather, he was making this statement in the context of arguing that African Americans should support his efforts to privatize Social Security, because since they died younger, their benefits would be inheritable to their family members, and this was the argument that he was making. But politics aside, the important point was that the president was aware that we had a health disparities problem, and that he was able to accurately indicate what that problem was and argue that it ought to be fixed, and I think he is right about that. So the social justice argument, I think, has done a good job of raising awareness of the problem, although it may not have been as successful as it could be at getting resources allocated to the problem. So some of my colleagues and I at our center thought that maybe we can help to create other arguments, other frames beyond social justice, and in this case, the utilitarian argument that perhaps there is an economic cost associated with having disparities. Perhaps there were inefficiencies in the economy that resulted from having people sicker than they should be. Perhaps there were resources that were being allocated unnecessarily and that those resources could be used for something else. So we did an analysis to try to calculate what was the economic impact on health disparities, what was the impact to the U.S. economy. And we estimated that at $1.24 trillion over 3 years. So when the argument comes at you and says, well, if we make this change, if we create this new program, if we go down, we change this policy, whatever that argument is that you're making, it's going to cost money. It's expensive and we can't afford it. The response, I think, is it costs money to maintain disparities. It's expensive to have health disparities as well. And so it is not a simple equation, change equals increased costs. It's also the case that lack of change or not changing has costs as well. And we need to also put that into our arsenal as we argue for resources. So now, for most people, disparities, it comes down to charts like this, which I will not spend a lot of time on, but it used to be that we would just show chart after chart of this sort of disparities by race and ethnicity, what I call the horror story. And I believe everyone should be forced to endure the horror story at least once in life. I'm assuming that you've all endured it, so I won't put you through it again. But this is just, I think, at its core, the disparities by race, ethnicity, and gender, showing that men are worse off than women, regardless of race, of race or ethnicity. Another good study that I like, this one is from the VA system looking at use of procedures that are only indicated for patients that have had a sustained period of time of poor quality care. If you just look at that first column, for example, limb amputations for diabetics, that should only happen if a patient has received poor treatment for a sustained period of time where they progress to that. And we say more than 3 times more likely African Americans are compared to whites to be limb amputated. This is from some guy named LaVeist did this study, looking at patients that were appropriate candidates for cardiac catheterization, an invasive procedure to diagnose heart disease. 100% of these patients, we abstracted about 10,000 medical records from 3 hospitals in Baltimore, and I guess I owe it to my employer to say Hopkins was not one of the hospitals, but I don't think the results would have been any different if it was. But every one of these patients, 100%, should have been referred for catheterization. But we see not only do we have a disparity problem, but we also have an overall quality problem because the white patients were only at 80% when they should have been 100%. These were all insured patients that were seen at the hospital. And this last one is from the VA system. One of my favorite studies, and why I like this study is because it was in the VA system, so these are all insured patients with the same insurance being seen at the same facility by the same set of physicians who are all working on salary. So there's no economic incentive to provide or not provide care, and we see a disparity, and we see low quality, so there's both. So when it comes to health care, I would argue that much of the disparity is really about a quality issue. And the more that we link healthcare disparities with healthcare quality, I think the stronger the argument for change and intervention it becomes. So I think that much of what we are doing about health disparities is going to fail. And in front of an audience like this is probably a heretical statement to make. But it's what I think. And I think it's because we haven't yet stopped to diagnose the problem. We haven't yet stopped to diagnose the problem. It's as if a patient came into your treatment room and you just started prescribing pills. Now, there's some chance that you might randomly hit upon the right course of treatment, but your chances of doing that are much greater if we first stop and diagnose. And I'm going to talk about this diagnosis problem, and especially the 2 topic areas that I was talked about earlier, which was this idea of biological differences and the other argument about socioeconomic status. And then I'll bring up a 3rd topic, which is segregation, one that we don't talk about enough, and I think you'll see what I mean. So, how many of you are familiar with this drug? Well, let's do it the other way. How many are not familiar with the drug Bidil? Okay, so all right. Bidil is the drug. Okay, so I'll have to, I was hoping to not have to give the explanation. Okay, Bidil. This is a drug that was developed in the 1970s. So in the 1970s, new classes of drugs were coming out onto the market. Calcium channel blockers, beta blockers, and they were coming on to treat heart disease, and they were very effective, these new drugs. And some physicians started to see that the combination of these new classes of drugs along with two readily available generic drugs, the names of which I can never quite seem to get into my memory.
Isosorbide and hydrolysine.
Yes, isosorbide and hydrolysine. These two generic drugs that were available at a fraction of the cost of the new classes of drugs, this combination was a very effective therapy. And they started to see this experientially. So someone got the idea of, well, let's do a study to see if this really is the case or if we're just sort of saying this anecdotally. And they did this study and found that this new combination therapy was very effective. They published this article in the New England Journal of Medicine, and this was a great new discovery. We've now got this new therapy that's having this wonderful impact. But they didn't leave it there. They then got the idea that we could apply to FDA for a patent, for a methods patent, if we combine these two drugs together into one pill. And they do, and then there would be a financial windfall, of course. And they do this. FDA issues the patent. And then they're ready to go to market with this drug. And they go to FDA and say, okay, we'd like to go to market with the drug. And FDA says, no, you can't do that. Well, why? He said, well, because the paper that you wrote was well and good for the New England Journal of Medicine, but the trial was not done to FDA standards. So you need to do a new trial. Now, of course, there's not enough time to do a new trial because the monopoly would run out by the time they did that. So what would a good researcher do? A good researcher would go back to the old data set and do some data mining. And this is what they do. They do data mining, and they look at race, ethnicity, gender, everything you can think of, to see if we can find something in the data that would justify a new patent. And they do. They find that this new therapy that they've hit upon here is more effective in blacks. Now, I said that way intentionally. Now, let's stop for a moment, and let's talk about that terminology that I just used. The drug is more effective in blacks. Have you heard that terminology before? You had to if you read the scientific literature, because we even title papers that way sometimes. Now, let's assume that we had a drug, and we had black and white patients. And we do a trial, we randomize these patients, and we find that 75% of the black patients benefited from the drug, and 65% of the white patients benefited from the drug. First of all, that would be a phenomenal success, right? But that 10 percentage point difference would surely be a statistically significant difference, right? And that significant difference would lead to the publication of an article with a title that says, Bidil more effective in blacks. And we would all see that, and we would go on with that. And I'm assuming, and I hope that I'm right here, I'm trying to not be naive, hopefully, as researchers, as scientists, we would understand the nuance of what that statement means, and we wouldn't think that it means that literally the drug is more effective in blacks. I hope you would think that, but I'm not certain anymore. Because this is what they found when they went back to that data. They found that the drug was, as they said, more effective in blacks. Now, under the scenario I just gave you, is that drug more effective in blacks? Of course it isn't, right? If you were part of the 75% of black patients that benefited, then you benefited. If you were part of the 65% of white patients that benefited, then you benefited. It wasn't more effective in blacks. It was effective in more blacks. It was effective in a larger percentage of blacks, but it was not more effective. It either worked or it didn't work. It wasn't more effective. But when you use that terminology, that language in that way, then you get advocacy groups, including African American advocacy groups, including the Association of Black Cardiologists, the NAACP, and other groups. And then 2 years after the completion of the Human Genome Project, you go back to the FDA and you say, look, this drug is more effective in blacks. So we need a new patent, but this time the patent should be for only use in black patients. And FDA gives them the patent, right? Now, but says you got to do a new trial. So they do a new trial. But this time they do the trial only in black patients. And what do you think they find? That the drug is effective. Because Bidil is effective. It was effective in black patients and white patients and Hispanic patients and Native American. Any group of patients would benefit because it's an effective drug. It simply is. So they go back to FDA and say, look, we've done the trial correctly now, and we'd like to go to market with this new drug. And FDA approves that. And my question, and this is in 2005, right? So this is not 1905. This is not 1705. This is 2005, after the Human Genome Project had already demonstrated that at the cellular level, that there were no significant differences by race. Right? Now, my question is, who do you give Bidil to? Do you give it to this African-American gentleman that has one grandparent from Scotland, one grandparent from Ireland, and two grandparents from Jamaica? This is Colin Powell. Do you give it to this African-American gentleman who's got two grandparents from Kenya and two white American grandparents? This is President Obama. Do you give it to this African-American gentleman? Okay, this guy's got one Chinese grandparent, one Thai grandparent, one white American grandparent that has Native American ancestry, and then one black American grandparent that has Native American and white American ancestry. Who did he inherit his Bidil receptor from? And how do you know this? By looking at him across the table in the treatment room. And how do you know this? By asking him what his race is. And him giving you an answer, whatever that answer might be. So, by the way, what about this guy? Looks like a black guy to me, right? But of course, this is Vijay Singh, who is a golfer from Fiji, and he's not African American at all. Hopefully, Vijay will never need Bidil. However, if he does need Bidil, should it be appropriately offered to him, since he's not African American? So this is where we are. So when science, politics, and policy combine, usually science is going to be the loser. And even scientists will sometimes fall, as in people at the FDA, will fall into ways of thinking that are outside of the scientific process. The next issue is this issue of social class or socioeconomic status and race. And I'm going to just quickly go through this. It's not really a race issue, it's really a social class issue. It's really about socioeconomic status. So we just put together a few charts here. This is from the National Health Interview Survey, looking at disparities at different levels of education and showing that we see disparities across all levels of education, that it's not just that everyone seems to benefit by increasing education, but that it's not the case that if you are a racial or ethnic minority, that it's not really about race or ethnicity, it's really about socioeconomic status. Now, a brief message to the researchers, because I know some of you are probably thinking, well, we deal with that by using multivariate modeling. So the non-researchers in the room, please just bear with me for a moment. This is a message I must give to my people, the other researchers. Okay, now, I'm going to do a quick demonstration to the researchers on use of multivariate modeling to address this problem. And I'm going to do something that will come straight out of your Biostatistics 101 class. So you all have had this, and you've all been taught to do this. And before I go any further, let me say that if you go to the library and you punch my name up, you will find me having committed some of the very sins that I'm going to talk about right now. So this is not a case of let he is without sin cast the first stone. This is a case of realize that you have sinned, repent, go forward, and sin no more. So if you find me sinning in the future, you can criticize me, but You can't jump on me for some paper I published 10 years ago and didn't realize I was sinning because I was doing what we are all taught to do. So no guilt for any of you. Now, so I'm going to do a simple analysis here using the National Health Interview Survey. The National Health Interview Survey is the official record of the health of the American population. It is the standard done by the National Center for Health Statistics. It is a large sample. I'm going to use 33,000 adults over age 40, and we're going to look at three simple variables. Disability as measured by having an ADL limitation, activity of daily living limitation, which is a very low standard, just having one limitation. And we're going to look at race, black versus white, and we're going to look at income in three levels, okay? Less than $20,000, $20,000 to $75,000, or more than $75,000. So this is a very simplistic analysis. Let's see, what are we taught to do? What we're taught to do is first look at race and ADL, and which is what we've done. And this is an odds ratio, and this is the confidence interval. And non-researchers, please be patient. This will not be that painful. The odds ratio of 1.46 tells us that African Americans have 46% greater odds of having an ADL limitation or disability compared to whites. The confidence interval says that this is a significant finding. Am I right? Researchers, help me out here. I'm right? Right? So far I'm passing the class, okay. Next, we would do the same thing with income. The odds ratio is declining as income levels increase, which is what you would expect. That means that the odds of having a disability decrease by the more money you have. So people that are more affluent are less likely to have disabilities. And the confidence interval tells us that this is significant. So far, everything is exactly as you would expect, right? And this is straight out of Biostats 101. The next thing we would do is put race and income together, and we would see what happened. And here we've done that. And we see that the income of the finding is the same. Income continues to decrease. As income increases, the odds of a disability decreases, and that is significant. But look at what happens here. The odds ratio for black or for race is not significant. Right? So we would conclude what? That it's not really race, it's really income. Right? And then we would publish the paper, and we would get a promotion, and we'd get a raise, and all would be right with the world, at least our world, because what we would have just done is add false information to the research literature. Because if you had simply done this, which is not usually taught in Biostats 101, if we simply did a simple table and looked within each cell to see what was the rate of disability, we would see that among the lowest income group, there is a significant race difference in having a disability. And we would see that in the highest income group of $75,000 or more, that the rate of disability for African Americans is being calculated on the basis of only 8 cases, 8 people. So in the National Health Interview Survey, 30,000 people, there were only 8 African Americans with incomes over $75,000 that had a disability. So you are calculating a rate based on 8 people. Now, how confident do you feel about that in making national policy on the basis of 8 people? Okay, now consider that this is a National Health Interview Survey with 33,000 cases. How many papers have you seen with much smaller samples in much more complex analysis making definitive statements about race and health? I see some sad nods here. It is okay. This is not about guilt, okay? I've committed the same sins before I reached enlightenment. Join me in enlightenment. We must stop. It is false information. Here's another problem. This is a high school in the Baltimore metropolitan area. And this is the entrance to the campus. I'm taking a picture here. You see there are trees and a lawn, and as I drive onto the campus, there are some more trees and the buildings off in the distance. I come around to the side of the campus, and here's the gymnasium where the basketball team and the volleyball team and the wrestling team perform at this high school in the Baltimore metropolitan area. Here's another high school. This is an upper middle class suburban area outside of Baltimore. Notice that they have a lawn and some trees as well, but the buildings are clearly visible to the street. So I come around to the back of the building. Here's the soccer team going out for afternoon practice on a wide open field with no bleachers to accommodate the students, the spectators watching the baseball game. And then I come around to the side of the building, and here are the portable classrooms, because in this upper middle class community, the building is not adequate to meet the need for all the students that attend. And finally, here is a high school in the Baltimore metropolitan area. So, okay, there's no lawn, but if you look real closely, there's some weeds here in the crack. And you've got a tree there. There's a tree. So what is my point? And this is my last point to the researchers, so the non-researchers can get back engaged again. My point is that the graduates of each of these institutions are in your data sets coded as a high school graduate. So that when you do your analysis and you put education into your fancy, smancy, multivariate model, and you say, we've now created equal groups, and we can say something about race because we've accounted for socioeconomic status, I want you to think of this slide. Let it burn into your memories for a moment. Have you accounted for differences in the life chances and opportunities of the graduates of these institutions? Do you think that perhaps there are differences? And do you think that perhaps there are differences in the distribution of race and ethnicity among the students of these institutions? That's what you've done. This is why the strategies that we typically use to create this information that we put out to the public must be challenged. Whether or not these methods are actually producing the information that we think it's producing, or is it perhaps leading us astray? This is a corner store. This is actually a few blocks from my office in Baltimore. These stores are ubiquitous in northeastern cities. I'm sure they're not ubiquitous here, but they are ubiquitous. They're in every northeastern city. In fact, I have a collection of malt liquor and wine bottles cheap wine bottles that I collect from different cities when their own unique little brands of malt liquor that they all have. They sell malt liquor, cheap wine, cigarettes, and lottery tickets. This one is on McElderry, which is like 2 blocks from my office, this one here. And this one here is, I did not Photoshop this either, this sign. This is my favorite one, actually. And as I'm taking this picture, I'm actually standing in the parking lot of a funeral home. So it just seemed like a perfect moment, you know. And of course, this is L&M Liquors. They sell beer, wine, and medicine. And why I like this is because of the truth in advertising, because they do sell beer, absolutely. And they do sell wine, absolutely. And they do sell medicine, because the medicine that they sell is the elixir for the ills of poverty, malt liquor. And yes, that is a 64-ounce bottle of malt liquor. And that is a 64-ounce bottle of glass, by the way. This is part of my collection. I'm going to St. Louis tomorrow. I'm going to see if I can find some new, see if, I don't have anything, I don't have St. Louis in my collection, so maybe you can suggest some neighborhoods I might go to where I can find maybe some unique St. Louis malt liquor, This Green Lightning, this is from my hometown, Brooklyn, Green Lightning, because, it was St. Patrick's Day, right? And because, the malt liquor wasn't bad enough, we needed to add green dye to the malt liquor. And it's my favorite. But the 64-ounce bottle is really, it is an engineering marvel. It's made of glass. It is ergonomic, and it's heavy, but it is ergonomically designed for simple, easy, one-hand consumption. It's a thing of genius. It's evil genius, but it is absolute genius, and I'm in awe of them. Unfortunately, they've used that genius for evil rather than good. But anyway, so we did a study of these stores, these corner stores, to see where are they located. So people in the communities always say, these stores are always located in our communities. But we said, okay, how about if we actually tested that out? See if we can document that. And if we can, do we then create some evidence or information that activists can use to actually go out and advocate for change? And we actually did plot these stores in the city of Baltimore and found that they were almost exclusively located in low-income, predominantly African-American neighborhoods, segregated, low-income black neighborhoods. And this is one of the studies I'm most proud of because we were able to work along with community activists to then go to the Capitol and push for change. And what they did, one of the changes that occurred was Baltimore was the first city to pass an ordinance that disallowed billboards, tobacco and alcohol billboards, and several other cities quickly followed behind. I'll tell you more about that story later. There's a whole lot to it, but that's actually what happened out of that. So one last story before I didn't talk about the research piece. And let me just say, before I even get into this last story, that this story is about someone that I don't know who this person is. And you'll see what I mean in a moment. So the person that I'm going to talk about might actually be in this room. And if you are, I don't know that. And you're not going to want to claim this one. So just stay quiet. Just stay quiet, don't out yourself, and we won't have a problem, okay? So I'm in my office, and I get this request to review a paper that's going to be published in a journal, a really fancy journal. And I won't say the name because I don't want to make sure I'm not embarrassing anybody. It's a really fancy, smancy journal, right? And so I agree to review this paper. So I start reading the paper, and the title was something like, firearm use among black and white adolescent males, or something like, you've seen those types of titles, something like that, right? And unfortunately for this author, they did this study on data from the state of Maryland. And unfortunately, they sent the article to be reviewed by somebody that lives in Maryland. So as I'm reading through this study, I know all of the locations they're talking about. So they're saying that we got the sample from this community and that community, and I know all these places. And I started to notice that the white males are from Garrett County and Allegheny County, which is in rural western Maryland in the Appalachian Mountains. And the black males are from Baltimore City. And the white males are shooting long guns or rifles. The black males are shooting handguns, mostly. The white males are shooting at wildebeests or whatever they shoot at in Western Maryland. I've never been there. And the black males are shooting at, right? Now, I know lots of statistical trickery to get data to say all kinds of things, but I don't know the trick that makes this a comparison of race. This is a comparison of rural versus urban environments, perhaps. It's a comparison of one type of hunting culture versus another type of hunting culture, maybe. It's a comparison of many possibilities, but it's not a comparison of race. Now, that's an extreme example. I hope the author's not here. Just, it didn't get published, and so it's not out there in the world. Needless to say, I wrote a long review of it, and it didn't get published. This is an extreme example, of course, but it makes a point. The point that I'm making is that the United States is a dramatically racially segregated society. So when we look at national statistics, are we reflecting differences in the risk environments that people are exposed to? It's almost like as if you woke up in the morning, you put on Good Morning America, and they say the national temperature today is going to be 42 degrees. Now, does that statistic help you very much? Do you know if you need a coat? But this is what we're relying on. Not to say we don't need national data. Of course we do. But if we want to take action, we must go well beyond national data because the national data doesn't tell us the full story, right? So what we need to do is to have places where people are living under similar conditions. So we got the idea that can we find communities that were racially integrated and where people had similar levels of education and income? Could we identify these communities throughout the country? And then if we can, go into these neighborhoods and collect data on these people and see, do we find the same disparities that we find in the national data? And if we don't, then perhaps this tells us something about how the social environment is impacting people's health. And if that's the case, then perhaps there is not something inherently different about people of different racial ethnic groups that produce these disparities, because the problem with that argument is that we're left with two possibilities. Either we will find some therapy to counteract the gene, right? Good luck with that. Or we can't do anything about it at all, and the disparities are intractable, and they'll be here forever. So why continue to devote resources to it? So we went around and we looked into the census, and we said there are 168,000 census tracts in the United States. How many do you guess met the criteria that we established as being racially integrated and without race differences in income or education? Well, the answer was 425 communities throughout the country. And fortunately for us, most of those communities were in the Mid-Atlantic region, including Maryland, and some were even in Baltimore City. So what we did was we put together 2 of these census tracts that were contiguous, and we made that our first study area and said, okay, let's collect data here. Let's work with this community. And actually, if there's enough time at the end, I'll talk a little bit more about how we work with the community. But we went into the community, collected the data, and we replicated parts of the Health Interview Survey and NHANES, which is another federal data set that we also rely on for our data. So this is just a kind of a profile. This is from the 2000 census, a profile of these 2 census tracts. They were 44% white and 51% black. As you can see, it's a very low income area, but there are no differences by race and in income. Poverty levels are much higher than national poverty levels, but again, no dramatic differences in poverty levels. Educational status was also very equal across the 2 groups. So the thing about doing research on humans as opposed to doing research in animals is that when you're working with rats, you're able to control the environment. You're able to control everything. You have laboratory conditions. You can control the humidity, the temperature, the nutrition, how much light, everything that they get. Humans are much more complicated because we could do that with humans, but the human subjects reviews committees probably wouldn't let us do it, so we can't really do that with humans. So we have to try to find ways, places where we have naturally occurring environments where maybe we can control some of these things and be able to do these kinds of tests. So we went into these 2 census tracts. We did an interview of using the protocol from the Health Interview Survey and NHANES. Blood pressure was one of our primary outcomes that we focused on, and we were successful at interviewing 42% of the adults in these 2 census tracts. We didn't sample. We went in and tried to interview everybody. And over a 12-week period, we were able to get 42% of the adults, which is a phenomenal number, phenomenal response rate, by the way. And if we have time during the Q&A and you want to know, I'll tell you how we were able to do that. I'll just give you one little clue. It had a lot to do with being an experienced parent. But so if you want to know, ask about it. So quickly, first, how well do we reflect the community? So in blue is our sample, and red is the census. And this is the distribution of what we got. As you can see, we did a fairly good job of representing the community in terms of race here. We did a great job of representing them in terms of income levels. Education, also a fairly good job, although we're a little overrepresented in this group. And this is sex, gender. So I think the sample is pretty representative of the community. So let me just back up and say, so what I'm going to show you is we did analysis using a national survey, either the National Health Interview Survey or NHANES, and then we do the same exact analysis in our sample. And what we want to see is, do we have the same disparities? Or are disparities different when people are living under similar conditions? Okay, so this is the first one we did. This is on hypertension. And these are just different models. You can ignore this. This is different models adjusting for different variables. But what they're all saying, using NHANES, this is a national sample, is that the odds of a black person being hypertensive is about double the odds of a white person. No matter what other variables you account for, that's consistent. When we replicate those same models, we find much smaller disparities, but they are still significant. But they're smaller on the order of about a third. Almost a third of that disparity is explained. So that means that there's something more happening with hypertension, more than just the physical environment, but it could be something about physiological response. It could be about people's physiological response resulting from their trajectories on life, how much exposure you've had to that stress, how sustained has it been, what other places have you lived. But when we do a similar analysis looking at other conditions, we do find that in every case, either the disparity disappears entirely or they're much smaller. So here, diabetes, we find no significant race difference in diabetes among people living in the integrated community. We find no significant race differences in obesity among women in our community compared to the national study, which finds 87% greater odds of being obese if you're a black woman. This is the hypertension finding that I already showed you. And then access to health care, we actually find that the African Americans in this community are more likely to have utilized preventive health care compared to the whites, whereas in NHANES we find no difference in use of preventive health services. So in imagining how we would resolve the health disparities problem, or how we would get to the point of having that utopian society that I asked you to imagine, where there were no disparities, if the answer that comes to your mind is that this is a biological thing, and there would be some pill that we would offer, I think that hopefully this would suggest that that won't be the way that it'll happen. If the idea is that disparities really don't exist, I don't see color, it's really social class. This community was a low-income community. It's a very poor community. And the disparities that we have there, the reason that we've equalized the disparities in this community is not because the black rates were lower. It was because the white rates were much higher and equal the blacks. Anyone living in that community is going to be sick, period. Smoking rates were 3 times the national rates. Over 75% of the adults living in that community were at least at one time in their life a smoker. 75%. In the national data, it's usually around 23%. There is no physician practicing in these 2 census tracts, no dentist. There was no pharmacy. There was no supermarket. It's a classic food desert. The only stores there are stores that sell malt liquor, cheap wine, cigarettes, and lottery tickets. There are no fast food restaurants there. McDonald's is not in that community. There are no chain stores at all in these communities. So we can't blame this one on McDonald's either. The food that's available there are mom and pop fish fries, selling basically deep fried fish and chicken and other foods of that type. So the infrastructure to sustain a healthy lifestyle simply does not exist in that community, and anyone that moved into that community would be sick. So the disparities that we see by race, we would argue, and I would argue, are largely a function of place rather than race. The disparities that we see has a lot more to do with your zip code than your genetic code. So how this plays out. Today we are having a meeting around health disparities. And somewhere else in this town, there are groups meeting about 3 other disparities, which I call the 4 great gaps, the 4 great disparities. Health, wealth, education, and criminal justice. And by that I mean incarceration. But what we don't realize enough of, I think, and we don't meet in this way because we meet in our own silos. What we don't realize, I think, is that our disparity is being caused by their disparity, and their disparity is being caused by our disparity. That is all part and parcel of the same problem. That we know that education is one of the most well-documented predictors of health, and that children are less healthy or less able to get an education. We know that education is associated with who gets incarcerated, and that that illiteracy rates are extremely high in prison. And of course, while you're in prison, you're not in school, especially for juveniles. We know that if you have the wealth to afford high-quality legal services, you're less likely to wind up in prison. And the best way that I can imagine to keep a group of people from developing wealth is for them to be in prison between the ages of 17 and 34, which is the period of life where most people are developing the human capital necessary to create wealth. The health and wealth relationship is well documented, and we know that people wind up in prison because of undiagnosed and untreated mental health problems leading to poor impulse control and behaviors that land them in prison. And we also know people come out of prison sicker than they were when they went into prison. So none of this is probably surprising to anyone in this room. But this is not the way that we think. We think in terms of our silos. This is health, and this is the education problem, and this is for the criminal justice people. But now realizing that there's really an interconnected nature to all of these problems, and that health is the outward manifestation of underlying inequities that exist within society. It is the symptom. Our disparity is the symptom, not the genesis of the problem. And I'm going to end with one last comment about this. So how many of you here are aware that there are more black men in prison than there is in college? Okay. Have any of you bothered to actually pull the data and see if that's true? Well, of course I did. And this is what I found. So, in 2006, there were 836,800 black men in prison. That is way too much. And nothing that I'm saying should suggest that I'm saying that that number is not too high, because it is. But in that year, there were also 896,000 black men in college. So there were more black men in college than in prison. Now, the college-age population is generally going to be between the ages of 18 and like 23, 24, right? Whereas the prison adult population is going to be 18 up. Now, so let's say we only looked at ages 20 to 29. What do we find? Well, in that year, 310,000 black men in prison, 480,000 black men in college, more black men in college than in prison. Now, again, I asked you how many of you were aware that there were more black men in prison, and most of you raised your hand. This is not about blame, right? This is about repenting, going forward, and sinning no more. So my appeal to you is to join me in what has been a one-man crusade to dispel this terrible lie and myth that's being perpetrated about black men. Even our black male president made that statement, that there are more black men in prison. So don't feel bad, they're all saying it. But it is not true. And I will end there, and thank you for your attention. So, I don't know if there's time for questions or anything.
We'll bring the microphone right up. Hold on just a second. It's got it right here.
Loud voice.
I'll grab a...
Thank you very much for your presentation. I guess that you are raising many things that I work with immigrant populations, and I always ask myself, are Latino immigrants more Latino or more immigrants? And I guess that that's something that we have to understand, because the people tend to use the category of Hispanic, and if there are differences among African Americans, which is a category that I refuse to use, I would submit that there are more differences among Hispanic immigrants and non-Hispanic immigrants. Among Hispanic immigrants and non-immigrant Hispanics than among Hispanic immigrants and Ukrainian immigrants. What I mean is livelihood. Besides the four categories you have mentioned, livelihood, the moment of your life you are into also plays an important role on your health access. So I guess that health literacy is an other very important variable that we have to add to understand how to take care of, especially in the Midwest where we have now huge numbers of immigrant people coming here. So I really thank you for your presentation.
Well, I couldn't agree more with you on several levels, several of things you said. So, for example, my mother is from the Dominican Republic, so I'm a black Hispanic. My father is from St. Martin, so he is Caribbean. They met in the United States and had children born here, of which I'm one. So what am I? I'm a black Hispanic with Caribbean roots, right? So I'm all of those things. So, especially if you look at the black population in this country, and if you understand anything about fifth grade American history, you know that my story is not as unique as you might think. And that if we were to canvass the black people in this room, I bet you they're going to all have stories of that type. You're going to find people with backgrounds that include Native American, European ancestry, Caribbean ancestry. So culture is a complicated thing, and the history of this country complicates that because of the way that cultures were treated. Some cultures were were nearly entirely wiped out, for example, in the Native American community, and how that, so there's just so much there. So I could do a whole lecture, and I do, and didn't do it today, on just what do we mean by these categories. And we could, the category Hispanic, which is the term that I tend to use because that's what my mother prefers, and so she told me to use Hispanic. But if you look at that category, what is that? That's people that are from countries that were once colonized by Spain. That's the best I can do at defining that. And then you add Portugal, and then you add Brazil to that, which complicates it, right? Because they were from Portugal. So even that doesn't entirely work. But you look at the cultures. I mean, my mother, who's Dominican, she moved to Arizona for a while, and her biggest complaint about living in Arizona was that when she spoke Spanish, everyone assumed she was Mexican, and she hates Mexican food. She doesn't like Mexican food. It's so different than the Dominican food, and she wanted to come back to the East Coast where she could be around Dominicans and Puerto Ricans and Cubans because she could understand the food because the food was so different. And I got a million stories like that, I can tell you. But you're right. The idea that human variation can be placed into categories, there are, of course, many people that comfortably fit into the categories, which is why the categories exist. But there is a large proportion of people that do not comfortably fit into any categories because human variation is not categorical. It's across the spectrum, and we all find ourselves falling in different places on these spectrums. There's a question over here.
Thank you for a great presentation. I'm Will Ross. I'm an associate professor at Washington University. I work with a colleague of yours at the CDC, David Williams, on this subject at our Disparities Roundtable. I have a question about the quality issue. I agree wholeheartedly based on another IOM report, a 2001 IOM report, Crossing the Quality Chasm, really documenting that quality first. Yeah. And if disparities elimination leads to improved quality, then that certainly would be the greatest impetus for driving practice and research. How, as you span the American academic medical centers and hospitals, how many centers do you see really making that connection, actually incorporating disparities reduction as a measure of quality, documenting that, as a performance appraisal? I can only think of a couple. I just came back from a Malcolm Baldrige meeting in D.C., and the Henry Ford Hospital was certainly ranked among those systems, as well as you know, and I just won't mention some of those systems. Okay,
sure,
no, I won't mention any systems, but I just didn't see a whole lot of that being embraced and codified in some of the academic medical centers that I'm familiar with.
Right, you're right about that. But I am, in spite of the work that I do, I'm a very optimistic person. I'm very optimistic, and I know that is coming. So we have a group that we put together called the Culture Quality Collaborative, which is a group of hospitals that we brought together from around the country that are working on disparities in quality, cultural competency, and health literacy. We have 14 hospitals in that collaborative, and Henry Ford is one of our founding members of the collaborative. So I'm very familiar with what they're doing, and they are far out ahead of the industry, without a doubt. There are some other hospitals that are doing well, but up until very recently, there was this widely held belief in the healthcare industry, especially in the hospital sector of the healthcare industry, that it was illegal to collect data on race. Now, the genesis of that, there was some kernel of truth there. In many states, it was illegal to collect data for insurance companies to collect data on race because of discriminatory practices in the past, using race to redline and not provide insurance, mostly in the housing market, not in healthcare. It was mostly a housing market thing. But the laws came across and said insurance companies can't collect data on race at all. So that was the kernel of truth that led to this widely held belief that permeated the industry. And many hospitals didn't collect data at all on race, at all, right, until very recently. But now we have the meaningful use standards that are going to guide how the electronic medical records roll out, and we will be collecting that data. You look at the regulatory environment, NCQA, Joint Commission, URAC, all have standards now that deal with cultural competency. Even the CAPS survey now has a cultural competency and health literacy component to it. I mean, I think the regulatory environment is changing, and I think that the other policy imperatives are moving us in this direction. And I think that we will start to see more healthcare organizations looking at quality between by not just race, but race, ethnicity, and language. That would be, and also gender. This is another issue. I think it was the Joint Commission that, I'm not sure which regulator it was right now, so don't quote me on that. Has recently come out with a report on gender and looking at transgendered people and categorizing that data. So I think there's movement happening, and I think a lot is happening. The patient-centered medical homes. If you look at the PCPCC, which is there's so many acronyms in this business. They are pushing down an equity path as well, and they're really driving the way that the patient-centered medical homes are going to play out. And of course, that's going to become the dominant primary care model in the country over the next few years. So I'm very hopeful that we're going to have change because I see the beginnings of it right now. Excuse me for all the acronyms, but that's the industry that we're in. Is that it? No other questions? You don't want to know how we got that response rate? What the parent teaser was all about? Okay. So what it was the interviewers were a combination of students from local colleges and community residents. Not residents of the community we studied, but residents of nearby communities, because we wouldn't want to contaminate the research in that way or jeopardize people's privacy. So since the interviewers were people that we trained, and they weren't people who came with existing knowledge of research, and they were not aware that that it was utterly unrealistic to get a 42% response rate in 12 weeks. So being an experienced parent, a little carefully crafted use of deception. So I told them that we were going to get 75% of the residents in the community in this survey. And they believed it because I said it. And so it must be true because I said it was true. Although that was a completely absurd number. I said, we're going to get 75%. And we put together this really great incentive program and it wasn't individual incentives. If we as a group get to this number, then everyone gets this reward. If we get to that number, it was very elaborate. And of course, if we got the 75%, it was like the ultimate award. We were going to take them, and it was going to be really nice to take them out somewhere. And of course, at the end, they were all disappointed that they only got 42%. And at the end of the study, I said, "Do you have any idea? But 42. If we had 33%, I would have been happy. 42% is phenomenal, and you should all be happy. And we're going to give you the top prize anyway, because I never thought we would get 75%." So we motivated them with an incentive program that was not individual-based, but rather group-based, so they were able to work as teams as opposed to be competitive, and they used teamwork, and they worked in hard because we did a lot of things like that to keep it light, make it fun, and of course, give them unrealistic goals to try to achieve, and they worked very hard to try to achieve it. So, which is what I do with my kids, and come see me in about 20 years or so, and I'll let you know whether or not that worked out. But it's what my parents did to me, so.
Well, please join me in thanking Dr.
Thank you.
Thank you.